I think someone. So, Dr. Ashukan sir, can we start, sir?
Yes, we'll.
Yes.
What about Professor Jayanta Roy?
Dr. Roy has already joined, sir. He's there. Dr. Jayanta Roy, sir. So, Dr. Ashukan sir.
Hear me?
Yes.
Yes. You are very.
Yeah,
good.
I
What
mean,
about,
my
Professor
video is
Jayanta
not
Roy?
working. Let me check.
Dr. Roy.
Okay, sir.
So, with your permission, sir, can we start?
Yeah, definitely.
Okay.
Ashukan sir, please.
Yes, sir. We'll start.
Yes, sir.
Hello and good evening, everyone. I am Dr. Ajinkya Nanavre from MQR Pharmaceuticals.
Hear me?
Yes.
I welcome everyone.
Yeah, I mean, my
workshop
video
in
is not
acute
working.
ischemic
Let me
stroke.
check.
In the previous workshops, we had very unique and interesting case
Okay, sir.
discussions, and with your permission, sir, can we start a fruitful
Yeah,
discussions
definitely.
today as well?
Ashukan sir,
The
please.
Yes, sir.
objective of this
We'll
workshop
start.
is to
Yes, sir.
showcase unique cases in the management Hello of
and
acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course
Yeah, I mean,
director.
my video
And
is
it
not
is my
working.
honor
Let me
to
check.
introduce our faculty
In
for previous workshops. We had very unique and
sir.
interesting case
Okay, sir.
discussions, and with your permission, sir, can we start a fruitful
Yeah,
discussions
definitely.
today as well?
Ashukan sir,
The
Yes, sir.
objective of this
We'll
workshop
start.
is to
Yes, sir.
showcase unique cases in the management of. Is my screen visible to everyone? And gain
Yes.
insights from the moderators and the wisdom shared by our course director. First, I welcome. It is my honor to introduce our course director, Dr. K. Achokan sir. Sir is Chief Neurologist and Head of Neurosciences at Department of Sri Ramakrishna Hospital, Coimbatore. Sir is a life member of Indian Academy of Neurology and Neurological Society of India.
Yes.
Sir has been also a member of Indian Academy of Neurology. Sir is member of Movement Disorder course director Society of India. Sir is president of Coimbatore Neurological Society and president at Tamil Nadu and Pondicherry Association of Neurologists. Sir has presented many national and international conferences in neurology. Sir has presented many papers in many national and international conferences on stroke and epilepsy, and conducted various international drug trial studies in the department. Sir has special interest in the stroke therapy. Dr. Asokan sir, welcome. Then I welcome Dr. Jayanta Roy sir. Sir is director at the stroke program and senior consultant at Department of Neurology of Institute of Neurosciences, Kolkata, and epilepsy. Sir is certified neurosonologist accredited by American Society of Neuroimaging, special interest in 2005. Sir is recipient of American Society of Neuroimaging William McKenney Award for the best manuscript based on the clinical research in neurosonology. Sir has been executive committee member of Society of Neurosonology of India and member of educational committee in the Joint Stroke Congress, Hyderabad. Sir has over more than 36 publications in various reputed national and international journals. Sir is also editor of various neurological books. Sir has been guest faculty at the many prestigious national and international neurological meetings and conferences. Dr. Jayanta Roy sir, welcome. Then I welcome Dr. Mukherjee sir, our second moderator for tonight. Sir is Principal Director and Head of Neurology, Max Super Specialty Hospital, New Delhi. Sir has been member of International Stroke Society, core member of Indian Multiple Sclerosis Forum. Sir has been awarded by Chief Army Staff Commendation Medal. Sir has won Best Paper Award for the Stroke in Young in Epicon, Mumbai. Also has the Lifetime Award of Human Charitable Trust. Sir has several national and international publications. He has given over 100 talks and lectures in various forums. Sir has been investigator in many research activities. The areas of interest are stroke thrombolysis, Botox therapy, headache, multiple sclerosis, epilepsy, and Parkinson's disease. Then I welcome our first expert speaker for tonight, Dr. Divya Goel. Ma'am is senior consultant and HOD at SSB Heart and Multispecialty Hospital, Faridabad, Ma'am has ma'am has more than 10 publications in multiple journals and has memberships of Indian Academy of Neurology, Indian Epilepsy Society, Indian Medical Association. Ma'am has expertise in IV thrombolysis, administration of botulinum toxin, and plasmapheresis. Dr. Divya ma'am, welcome to No Thrombosis workshop. Then I welcome Dr. Bhushan Joshi sir, our second expert speaker for tonight. Sir is consultant neurologist at Manipal Hospital, Kharadi, Pune, has experience in neurology OPD, headache clinic, Parkinson's disease clinic, neurological emergencies and neurocritical care team, electrophysiology department, and Botox clinic. Sir has established stroke unit in Columbia Hospital, Pune, which is now accredited by European Stroke Association. Sir also has multiple publications and presentations. And with this short introduction, I would like to hand over this session to our course director, Dr. K. Asokan sir, for his opening comments and context settings. Dr. Asokan sir.
Yeah, thank you, doctor. Thank you, doctor. Good evening, all of you. I thank every one of you for sparing time to attend this web meet today. I thank Team MCure for arranging this meet and setting the platform to discuss our thrombolysis therapy and mechanical thrombectomy. It's rather going to be more of case discussion. Hello, can you hear me? Hello.
Yes, sir.
Yes, sir, you are audible.
Yeah, it's
Yes, sir.
more of case discussion. We discuss our practical problems and get the solutions for the same. By listening to our expert speakers and their expert comments, we will be definitely benefited. And because these experts are really very rather popular and famous in the field, and I should thank the speakers for accepting our invitation and ready to share the cases, their cases today. And we have Professor Jayanta Rai and Professor Colonel Mukherjee with us to moderate the session. And we have Dr. Divya Goyal and Dr. Bhushan Joshi to share their cases. So I thank once again all of you, and I invite Dr. Divya Goyal to present her case. Dr. Divya Goyal, please go ahead.
Thank you, sir. Thank you for the opportunity. Thanks, Team MCure. And I'm really honored to speak in front of such eminent neurologists. Just sharing my screen. So is my screen visible to all?
Yes, very much.
You can go in presenter view.
Yeah. So I'll be presenting a case who presented to us in emergency after about 5 hours of suffering from a global confusion. So let me start with the video, which was a pre-thrombolysis video of this case when he presented to us and he was in the ICU. So I hope everybody can listen. So what I'm doing is I'm showing a coin to the patient and asking him, what is it? Tell me the name of the object. He was unable to do so. And then we handed over the coin in the hand of the patient just for the tactile stimulus and know if he could answer it. He couldn't do any of the activity, neither by visual stimulation nor by tactile stimulation. So the second thing that we presented was a bunch of keys, and he could not recognize the same. Right. So as we can see that the patient seems totally confused and there is no response. He's just thinking over as to what is the object. And when we tried to show him the action that this is inserted like this into something to open it up, even then he was unable to actually answer what is the object. So even despite the clues given to the patient, he couldn't answer. I hope the video is audible. Actually, I cannot hear the video.
No, video is not audible.
Probably. Then we tried showing a pen to the patient. He couldn't answer the name of the object or the purpose for which it is used. So after that, I opened the cap and gave him the lid that try to answer what is this. He was unable to answer the same. So despite showing multiple objects, he couldn't answer any of it. Right, so there was a complete anomia for the objects, and he could not tell the use of the objects as well. He seemed totally confused, and that was his presentation. So he was a 54 years old male who presented with this kind of global confusion. Actually, the onset was pretty much 5 hours when he presented to us rather than 4 hours. He had a sudden onset confusion. There was difficulty in writing, reading. He was not fluent. He could not speak anything. He could not comprehend, especially for the complex sentences. Then the second activity that we gave him was clock drawing. And we can see that when he drew the clock, what he did was a repetition of number 13, 13, 13 in all the ends. And when I asked him to draw the 2 hands of the clock, this is the cross is what he made. So he had no clue how to draw it and what to do with it. And there was repeated repetitions. So then we asked him to copy a clock, which I made it for him. And then we saw the activity. And he drew a circle well. The size was okay. And then he wrote the number 9 and tried a number 10. And then he repeated those 10s several times, as we can see 10, 10, 10 progressing. So the concept was lost. There was a conceptual loss. He could not understand the importance of the numbers as well as the spacing of the numbers or the timing. So all these, all the parietal lobe activities was actually affected. Then he could copy a 1, 2, 3, 4, 5, and then repetitions of 5, then 6. So made certain mistakes, corrected certain mistakes, and then 6, 7, 6 again. So when we asked him to copy the hands of the clock, what he did was he could copy the smaller hand, I suppose. He tried to make a center, but ultimately the center was misplaced. So this was actually a post thrombolysis MRI that we took just for the residents to see whether what is the location of the infarct. So this was not a pre-thrombolysis picture. We took just a CT, and since we were already short of time and we couldn't find a proper infarct on the CT, there was just a insular ribbon sign on CT, which actually is not available with me right now. So we tried to thrombolyze him at the 5th hour. So he was thrombolized with injection tenectease. We thrombolized with 0.2 milligram per kg, and an initial hemorrhagic transformation occurred 2 days post thrombolysis. Normally, what I tend to find in my practice, the patients, normally they end up showing improvement within the first hour of thrombolysis. So all these videos that I showed you, the clock drawing and the question making, all these were done post thrombolysis about 4 hours after thrombolysis when the patient seemed stable. And this is a follow-up after 2 weeks when he presented to me in the OPD. Actually, I think the volume is not working. I don't know why. So basically, we asked him his name, all the objects, and he was able to answer well. Can I make the sound work somehow? I have no idea, no clue where to, because the volume is full. Yes, the volume is full. The audio is not working. I'm so sorry. We asked him questions and he was prompt in his response. He identified the pen. He identified the other objects. He gave us his name. He gave us his address. And then we asked him to draw a clock. So this was the good circle that he made, a full-sized circle. And then he was able to write down all the numbers almost with a good spacing. without any more confusion or something like that. So this was the result gained after 2 weeks of thrombolysis. And I asked him to draw 10 past 11, which he did well. So there was a lot of improvement. He was identifying all of his relatives. He was identifying all the objects. His comprehension was better. His fluency was better. And definitely his reading and writing abilities also improved. So this was the first case with a relatively late thrombolysis that we had. But yes, it was effective. I do not have much of the data for case 2, but just was an interesting one to he presented to us. This was a 44 years old male who presented to us with severe imbalance, inability to sit, swaying through the truncal area, and there was a lot of nystagmus with fast component to the left side. And we conducted an MRI stat, and we could find that there was a large infarct in the left cerebellum. And in comparison to FLAIR, there was a definite mismatch. So we tried thrombolysis at about 6.5 hours after the onset of the symptoms. And what result was found is, this is again a video 1 week post his discharge. He was walking normally without any sense of imbalance, no vertigo at all, no nystagmus, and he was confident while walking. So I just wanted to show that even in diffusion flare mismatch, when we had a lot of hours already passed, it was 6.5 hours after we thrombolized, but we still gained results because it was not fully developed on flare. So these were 2 interesting cases that I wanted to show. Thank you.
Thank you, Dr. Divya Goyal, for your excellent presentation. Your both the cases are very interesting cases. And the first one, as you said, of course, present with aphasia.
Yes, sir.
Speaking difficulty. Rather, if you go by again NINS score, NIHS, I mean, NIHS score may be low, less than 4, what it may be.
Yes, sir.
As we have discussed many times,
Yes,
is a disabling disability like aphasia or hemianopia in professional drivers, etc. Even if it is less than 4, we do thrombolyze. Like this, you thrombolyzed, and you said 5 hours. Of course, early thrombolysis gives better results, but 5 hours not bad. Now people accept up to 6 hours. The only thing is, if you are in doubt, as we did, go for MRA, DW perfusion mismatch. And the thing is, if it is there, it's still going to work. But now, as you know, there are studies that are encouraging thrombolysis and anti-circulation strokes up to 6 hours and post-circulation strokes up to 9 hours. 9 hours, with of course a small core and a large penumbra. But your MRI shows a little larger core, but still the improvement was good. And as you said, we do get improvement in an hour or 2, but most of the time we assess the improvement after 24 hours, and we really get to know the MRS, etc. at 30 days and 90 days. Anyhow, and he had shown the very good improvement after 2 weeks, improved well. But that's not only thing. You asked for only CT initially.
Yes, sir.
And because of aphasia, went ahead with this thing, thrombolysis, isn't it? You didn't
Yes,
wait for MRI and all those things.
Yes, sir. Actually, we were already short of time,
Yeah,
and
that's
already
agreed.
5 years, 5 hours
Agreed,
had passed.
agreed.
So I went into the CT and thrombolized actually.
Was there any large vessel occlusion at any time?
No, sir. We
Post
carried out
thrombolysis
a
also.
we carried out a CT angio as well. It was clear, and that actually made us confident to thrombolize. So that was the reason that we started with thrombolysis.
Okay, nice case. Professor Jayanta Rai, your comments, please.
Thank you, sir. Dr. Goyal,
Yes, sir.
both the cases are excellent in their own ways, both actually a little bit different from the standard way of thrombolizing patients. Regarding the first case, did you get a chance to look at the mechanism of this patient and the stroke mechanism in the subsequent investigations?
Yes, sir. Yes, sir. He was not a known case of hypertension or diabetes, but he had accelerated hypertension, an attack of accelerated hypertension about a month back, and he was dyslipidemic. We got a thrombocheck panel also done. He was high on homocysteine. All the factors were negative. So, sir, dyslipidemia, hyperhomocystinemia, and accelerated hypertension. They were the three things. Probably because he was hypertensive just detected a month back, and he was not on any therapy for that. So the risk factors were not mitigated and he had a stroke. Holter and 2D echo and other stuff were all okay, sir, all clear.
Okay, so I mean, there was no evidence of any cardioembolic stroke as such.
No, sir, no, sir, no, sir.
In that
There was
location,
no.
at this age
Yes.
group, AFib is quite common. But anyways, so as Dr. Ashokan was mentioning that it was beyond 4.5 hours, and you went ahead with the based on a non-contrast CT scan, and you did a CT angio as well.
Yes, sir.
Yes, it is definitely a little bit courageous, I would say, to do a CT-based thrombolysis beyond 4.5 hours. Normally, we look for some more information. But since you mentioned that the CT looks good, so that means the stroke is probably, I mean, there is no definite hypodensity yet.
Yes.
So probably you were on the tissue window, presumably, and it worked out well in your favor.
Yes, sir.
So normally in this type of cases, perfusion imaging or diffusion flare mismatch would have favored or helped, like your second case.
Yes.
And regarding your second case, again, this young gentleman with a cerebellar stroke, that was again very good result, I would say.
Yes.
But in that case also, did you do a CT angio?
In that case, we didn't, sir. Actually, there was a diffusion flare mismatch, and we directly proceeded with thrombolysis. The patient was a bit, sir, short of finances, so we he couldn't afford the same. But we didn't even force him to. So we just proceeded with thrombolysis, and luckily we got the results.
Okay, excellent. Dr. Mukherjee, any comments?
So I think I must compliment Dr. Divya Goel for taking a very bold step and stepping beyond the. I think there's a lot of echo.
Mukherjee, you're probably logged in 2 windows.
Yes, sir.
That's why probably the echo is coming.
Is it coming now?
I think it's better because now you muted on both.
Is it coming?
Yeah.
So I've made myself mute.
Yes.
Yes, sir. You can log out from one device, other device.
Yes.
Is it okay now?
It is probably okay.
Yes.
So I think I must compliment Dr. Divya Goel for presenting two wonderful cases. And they were obviously not what is the garden variety of cases that we normally meet. I just wanted to know from Dr. Divya, what is the official protocol that you follow? I mean, this is an exception, but what is the protocol that you have? Every hospital has a protocol for stroke protocol. So are you aware? Do you have
yes, sir. Yes, sir. Yes, sir, definitely. So basically, whenever a patient of stroke comes, if the onset is within the first 4 hours and he has presented to the hospital, we conduct a CT along with CT angio. That is, and we call that code fast. And if we can find some findings in the CT, if there is a definite hypodensity, then first we look at the CT angio. And if there are no hypodensities obvious on the CT, sometimes we skip the CT angio, we directly proceed with the thrombolysis. And basically, sir, we pre-fill the syringe and we are open there in the CT room itself for thrombolizing the patient. If the stroke appears to be like a dense hemiplegia, or maybe the patient, we have a dense MCA sign or a large clot is seen, then sir, we definitely first proceed for CT angio first, and then we rule out if there is any definite blockage in the ICA or maybe the MCA territory, and we calculate whether the patient is fit for thrombectomy or thrombolysis. But nowadays, sir, what we have done that even if the patient is a fit candidate for thrombectomy, we first subject him to thrombolysis. If the thrombolysis actually fails, then we subject the patient to thrombectomy, even in the cases of large clots.
So, why I brought this, and this is open for discussion from all of us. if there is some time permits. So I have gradually switched over from CT to MRI.
Okay, sir.
We have developed a protocol where we announce stroke like you, we call it stroke code. And if that happens, the MRI is immediately made ready. Our radiologist is also on board in that stroke team. And the neurosurgeon, the neuroanesthetist, everyone is on board, and including our intervention person. So we do a MRI now first, because I'll tell you why we have realized this. A lot of things we go amiss. What we think is stroke actually turned out later to be something else. A large number of them, we can discuss that on a different forum. So we, to that extent, our stroke code is such that we can pull out a patient if a long MRI is going on, and we can put the stroke patient there. So we just need a diffusion weighted and flare. These are the only two that you can do in 15 minutes.
Yes, sir.
Or 10 minutes for that matter. And I think as the time barrier is extending, 4.5, 6 is all, now it is tissue clock which matters. So I think be more certain, and we should switch over to MRI in the hospitals where it is available. I know I'm making a controversial statement, but I would like to hear my other colleagues' viewpoints on this.
Yeah, Professor Mukherjee, you're very correct. And we are also slowly. In fact, for the past 4 years or so, we have been doing only MRI. All the fit cases who are otherwise not contraindicated for MRI, they're taken up for MRI, unless the patient is very restless, in such other patients also we sedate and do that. But for the contraindications, we do prefer MRI, because MRI is really readily available. And as you said, within just 10-12 minutes, we are getting diffusion weighted, flare, susceptible to varied image, and ADC as well as MRA. So we will come to know about the large vessel occlusion also in one shot. And if there is anything like that, then go ahead with angio and whatever may be DSA, etc., you thrombolize and take him with thrombectomy. We do agree. We are doing off late MRI. That's our first preference.
And the other problem that we have been facing, I mean, I'm just taking this forum to launch this thought process. Huge number of diffusion negative strokes we are getting. Huge number. You know, earlier, as we are growing in space and time, we realize that a large number of particularly posterior circulation strokes, they are diffusion very negative. So you don't know whether to thrombolize them or not to thrombolize them. They're classical presentation, and yet they're diffusion weighted negative. So I would like to hear from the house their viewpoints.
Yeah, you are absolutely right, especially in posterior circulations. It is quite well known. As you were going back to your first question, I mean, we do thrombolysis mostly on CT-based protocol. And I believe it depends on your hospital setting and which imaging is faster and where you are more comfortable. There is no hard and fast rule. But in our hospital, we mostly do CT angio, patients coming within the first 4.5 hours period. If patient comes beyond 4.5 hours, and if it is a large stroke, presumably an LVO, in that case, again, we do CT angio and sometimes CTP. If this is a minor stroke and we don't contemplate a LVO, in those cases, we prefer MR. We have a very strategically placed those two scanners side by side. So we sometimes switch between the two in some cases.
Okay.
Suppose you do a CT angio and I'm still in a doubt. So I do a quick DWI and then combine the two. But keeping in mind that if I'm treating the patient, this imaging switch should not delay my treatment. So that has to be kept in mind. Sometimes extra 5 minutes really doesn't matter if your decision is pending. But otherwise, I quickly treat the patients as Dr. Goel told in the scanner, CT scanner itself. And post bolus, I take them for the MR for more clarifications. So we use them depending on the situations. But yes, both are equally good.
Okay. Thank you, Dr. Roy. Just one thing I'd like to say. The posterior circulation strokes, as you all mentioned, sometimes very early strokes, very small strokes, especially things like lateral medullary syndrome, small infarct in the lateral medulla being missed. But in such of those cases, we could pick up in three Tesla MRI, Only thing, if you are clinically very definite about your lateral medullary syndrome, first circulatory stroke, very small infarct, in the MRI, the 1.5 is negative, still you can go for 3 Tesla. Or on base of the clinical this thing, if everything is negative, you can go ahead with thrombolysis. Your comments, Dr. Roy, Dr. Mukherjee?
Yeah. I mean, it's very true. And especially, I always include a coronal DWI with a higher B value. Because sometimes if it is a medullary stroke, then the axial cuts with a 1000 B value, they can miss a DWI lesion. So a coronal DWI sometimes give you a better visual with a higher B value, maybe 1,500 or 2,000. We don't have 3 Tesla machines in the emergency room. It is a another located place. So we use 1.5 Tesla, but the DWI coronal is sometimes helpful. Dr. Mukherjee, you have any experience?
So, you know what, I have been doing it, I'm not too sure about whether I'm doing, but if I have the clinical signs and symptoms and the time permits, and obviously there is no bleed, on the same basis as we do a CT negative, no hemorrhage, and we go ahead and thrombolyze. So if I get a diffusion weighted negative imaging on a patient who's got a posterior circulation stroke, classical sign, it has to be like a lateral medullary. I do this. I've been so far lucky. I hope one day it doesn't turn out to be, the tables don't get turned. So far, I have been thrombolyzing patients with very hardcore clinical signs, even if they are diffusion negative. But of course, clinical signs are very strong. That is what I've.
Thank you, Dr. Mukherjee, Dr. Roy, for your excellent disposition. Now I think we will go on to the next case. I invite Dr. Bhushan Joshi to share his case. Dr. Bhushan?
Yes, sir. I will be sharing the case presentation for Dr. Bhushan, sir. Yes.
So, good evening, everyone. And I'll want to thank NCare to allowing me to present my case in front of the eminent faculty. I've selected this case for the 2 particular reasons. He presented with seizure, so emergency department was not very sure about the diagnosis, and it was a posterior circulation with very high NIHS score. So I'll start with my case. So this is a case of posterior circulation infarct, and go to next slide. So this is a story of 36-year-old female. She is entrepreneur and she runs at least multiple preschools in Pune city and around, and very ambitious female. She presented at Sunday morning 4:30 a.m. with a history of sudden loss of consciousness, jerky movement, and frothing from mouth, as noted by her sister. There was no previous history of any fever, cough, chest pain. She before sleeping, she was absolutely all right, and she had that episode of seizure. So they brought her in our emergency department immediately. On arrival, when patient presented to our emergency department, we can go to next slide, please. Yeah, in her history, she was not having any history of previous diabetes, hypertension. There was no history of any chronic medical illness. She family refused any addiction. She positive history was she was on oral contraceptive pills. So next slide. And on arrival, hemodynamically, she was stable, 120, 70, 86 pulse. Her GCS on arrival, she was drowsy and confused. So E3, V2, and M5, and she was moving all 4 limbs that time. She was obeying verbal command, but there was some right-sided facial UMN type of a palsy, and her right plantar was upgoing. So whether it was a postictal stage or a stroke, we decided to go ahead with MRI scan. So we'll go to next slide. Can you play this video, please? So this is her diffusion scan. So there was cerebellar infarct, bilateral thalamic infarct, matching with the ADC diffusion, ADC restriction as well. So it was an infarct, and this scan was done around within 30 to 40 minutes from arrival of the patient. We decided, still she was in window period, so we decided to lyse the patient. And next slide. We thrombolize the patient. Next slide, please. Yes, even after thrombolysis, there was still a worsening of the condition of the patient, and her GCS dropped to almost 4. This is her pre-DSA video. If we can run this video. I mean, there was no motor response. I mean, this she collapsed literally in front of us in emergency room. Immediate CT was done to rule out any bleed. There was no bleed, and we shifted her to cath lab. As evidently as suggested by MRI, it was a posterior circulation basilar artery stroke. So we will move to next slide. Yeah, we thrombolize her with tenactiplase. I was suspecting large vessel stroke, so we chose tenactiplase in her case. 12 milligram bolus was given. There was no improvement. As we activate stroke code, so intervention team also get activated. Dr. Leomesh Birud is my colleague who is neurointerventionalist, and we shifted her to DSA, and we'll go to next slide. So as expected, it was showing top of basilar occlusion. So by next slide. So he was able to do this recanalization in 20 minutes. He was able to achieve TC score of 3, good circulation post thrombectomy. So total door to this TC score 33 time was around 1 hour 10 minutes or so. We'll go to next slide. This is a thrombus taken out. Please next. And this was a video recorded after shifting that patient from cath lab to ICU.
उर्मिला कशी आहे? हात उचल, डावा हात उचल, उजवा हात उचल, डावा पाय हलव, उजवा पाय हलव. गुड. इकडे बघ, उजव्या साईडला बघ. ठीक आहे, डोळे उघड पूर्ण. डोळे उघड.
Okay, next slide. So I mean, she was much better compared to pre-thrombectomy state, and this was 24 hours CT. Can we run? So some cerebellar infarct was evident. The thalamus appears to be salvaged. Left-sided thalamic small infarct is visible, but most of the parenchyma was salvaged. So if we can go to next slide. So post thrombolysis and after the thrombectomy, we carried out workup. She presented to us with an episode of seizure. So I was suspecting some embolic mechanism. 2D echo was normal. Transesophageal echo also was attempted. That was normal. We did Holter first. That was normal. Then later on, loop recorder was also we did it in her case. That also turned out to be normal. Peripheral smear for any hematological pathology, sickle cell was normal. Antiphospholipid profile was normal, and later on post 3-month follow thrombophilia profile we did. There was that thrombophilia profile was absolutely normal. So there were no apparent risk factor in this case. Only risk factor was we could find out was in next slide that she had a history of migraine, and possible risk factor, she was on oral contraceptive pill, estrogen containing oral contraceptive pill. So we discharge, later on we discharged her on ecosprin double antiplatelet and 40 milligram of atorvastatin. And her migraine, we are treating her migraine with propranolol and amitriptyline. And she is doing good. We'll go to next slide. So this was her post-discharge OPD follow-up. काय त्रास होतो मग सध्या तुम्हाला? So he had some dysarthria. Correct. Touch your nose. Correct. Or left side. Minimal left-sided ataxia. Finger was slightly impaired on left side. चालून दाखवा या रेषेवरती सरळ चालायचं. And she improved. That modified ranking score at this stage probably for is around, we can maximally say 1. She 3 months down the line, fortunately she is having no deficit and she is back to her normal life. We can go to next slide. So that was a case, interesting case, and despite of high NIHS score, and we decided to go ahead with thrombolysis, failed thrombolysis, then thrombectomy. Unfortunately, she responded to thrombectomy. It was, and because of stroke code, probably the entire team was available. So despite of confusional presentation with seizure, confusion of postictal versus vascular neurodeficit, scan, MRI-based thrombolysis and thrombectomy was achieved. So that is my case, sir. And sir, if you allow, I'd like to mention about my stroke code. As sir was saying, we are also doing MRI-based thrombolysis. Initially, we started with CT-based, but now I'm doing MRI-based. There were, one unusual problem I was facing with CT scan. After doing CT scan, patient sometimes we're asking for a report, and of course that CT sometimes may not show, is reported as normal, and so patient were refusing. There is no CT is normal, so I will not go ahead with this costly injection. That was one issue we faced in some cases. We could literally show them infarct in MRI. Second, sir, as sir mentioned, B2000 value, we have with our radiology setup, we have developed a stroke code MRI. So in that first sequence taken is B2000, sir. We don't take B1000 value. We directly take B2000. B2000 is almost like 30 to 45 seconds shorter compared to normal B1000. So that time is also saved. B2000 diffusion, then we take flare, we take GRE, and then we take angio sequence. That entire angio we go for brain angio. Neck angio is not covered in that stroke code MRI. So these 4 sequences we are able to finish in 8 to 9 minutes time, sir. And simultaneously we carry out family counseling. We can show them this is a stroke, this is simultaneously in MR console room, and that is helping our team to cut short actually the time spent on counseling. So we are probably compromising time spent on counseling versus MRI time, sir. And second, we are not having we are having 16 slice CT scan. So CT perfusion, CT multiphase CT angio is difficult in that, and it was taking longer time. And somehow radiology department was reluctant to give contrast without creatinine. Despite of multiple attempts, they were not convinced. So these are few reasons, sir. We shifted from CT based to MR based, sir. Yeah. Thank you, sir.
Thank you, Dr. Bhushan Joshi, for your excellent case. Yeah, that's what. I'll just start the discussion. Thing is, that's what you said, thrombolysis and thrombectomy. Of course, if it is a large vessel occlusion, your thrombolysis alone is not going to help. Somehow, you have to retrieve the clot. Such a large clot, I don't think you can lyse it with thrombolysis itself. You need to have thrombectomy. But if you go through the basics trial, which was released recently, they say all the posterior circulation strokes, best medical management, BMM, is as good as anything else. Thrombectomy may not be necessary. But practically, as you said, such a large clots, I think thrombolysis and thrombectomy, that's the way you rather retrieve the clot and get the patient better. One thing. Second thing, I wonder, did you have a pontine infarct? I think I missed
No,
your
sir.
first MRI.
No, sir. No.
It's only
I mean,
cerebellum and thalamus.
No, sir. It was not demonstrated in initial MRI. There was cerebellar infarct and bilateral thalamic infarct.
No pontine infarct.
No, sir. Brainstem was preserved in her case. It was
Yeah,
not.
that's it. Maybe that is one of the reasons for the better recovery.
Yes.
Yes. Brainstem pons is also involved. Of course, still they recover, but might take little longer time. Instead of processing within 4 or 5 hours, it might take 24 hours or a week or so for her to get better improvement. The pons was not affected, so improvement slightly better in this case. And the second thing I would like to say, see, when this history of OCP, of course, you got it later, and the stroke, and the seizure, what we think initially is venous thrombosis.
Venous thrombosis, yes.
Yeah, venous thrombosis rather than acute ischemic stroke.
Yes,
in your case, of course, the MRI proved it's only. I believe there was no venous clots, isn't it? There was no venous thrombosis in any of the sinuses.
No,
as
sir.
You went through the case. No.
I mean, venogram was not done, but yeah, of course. I mean, just based on the flow voids, no, sir. Venous flow voids were normal, sir.
That's what we think of because OCP and seizure. Yeah, otherwise, I think went on well. It's a good case. I congratulate. Professor Jayanta Rai.
Thank you, sir. And Dr. Joshi,
yes, sir.
You gave a very good point about doing MR with thrombolysis. I think I never thought about it.
Yes,
so,
I mean,
yeah, interesting. And I recall a story narrated by one of my good friend, Dr. Bijay Sharma from Singapore. They thrombolized a patient based on CT. And CT was normal. Then post thrombolysis, the patient was back to NIH 0. And the second CT was also normal. So the insurance refused to pay, but there is no stroke. Why should I pay? So he had to write a long letter to justify the treatment. So it is good point that you do an MRI and show them the diffusion. And secondly, I congratulate you for doing this excellent case, which is a glaring example of the beauty of thrombectomy in case of this kind of big stroke, especially basal at top, when there is a very high mortality and morbidity in this patient if they remain untreated. So this is the one of the best examples of this treatment modality, which has definitely changed our management. And I was very, surprised about not getting any clue of the stroke mechanism in this young lady.
Yes, sir.
Sometimes, we do find that there is no background cause or any other disease. So it's really intriguing sometimes. But some arrhythmias or something, we don't know, but young people may get this kind of embolic stroke, and when you find no reason at all. So,
yeah, sir. Sorry to interrupt. So we did loop recorder for 7 days that in search of arrhythmias. But in 7 days recording was not showing any arrhythmia, sir.
That's right. So yeah, we know that in almost in 25% cases, they still remain cryptogenic.
Yes, sir.
So anyway, very interesting and very well managed. Dr. Mukherjee, sir.
Congratulations. This was really very well done. And as rightly brought out by Dr. Jayant, basilar arteries thrombosis is catastrophic if not treated, and very timely treated, and such a big long thrombus brought out. Congratulations to you and your team member who did the intervention.
Yes.
Having said that, I think this case also exemplifies teamwork. That is what is very important, and the need to have a stroke team at 24/7 everywhere. I think that is what is required. And stretching this far, we all hospitals should have a stroke team. And I think more important is, I'm going beyond the scope of this discussion, the technical discussion. I'm looking at the comprehensive and the primary stroke centers. We need to have large cities like Delhi. What I'm told, I'm giving an example. There are almost 1,000 strokes every day, but I think only 10% receive the proper treatment. 90% do not receive the proper treatment. I'm sure this is true for all other cities, mid-size, small size, or big size.
Right.
It's time for all of us who are interested in stroke, to develop stroke protocols where stroke, at least the bolus of simple handheld CT scan or a mobile CT scan or some other mechanism is developed where the CT scan is at least done, transmitted to the primary stroke center or the comprehensive, and at least the bolus is given by a stroke physician. You don't have to be a neurologist to give stroke. I think 3 months training to a good physician who's interested in neurology will be good enough to prevent the disability because of stroke. See, cardiac arrest, cardiac things, you either recover or you don't recover. But in stroke, you're debilitated for the rest of your life. I think we all need to put our head, have a comprehensive interconnected stroke center. Supposing it happens in corner A, it doesn't matter. He should be admitted in A. Doesn't matter. The economics of it can be looked after by the government or by the federal structure. A stroke is worse than trauma. Like trauma is now getting integrated. There is national trauma. There is everyone. Like in Delhi, there's something called DACA. So whoever who belongs to Delhi, is a citizen of Delhi, if he gets admitted in any private hospital, the government pays it at CGHS rate. Same thing should be done for stroke. I feel we all are duty bound to espouse this cause. I think that's what the message that I would like to give. And thank you very much for presenting such a wonderful case.
Thank you, sir. Thank you.
Thank you, Professor Colonel Mukherjee. At the end, I thank both the moderators and both the speakers for the excellent discussion. I think we learned many things, and every time we are learning new things. Today also we learned many things, and I thank every one of you. And host, any questions in the question box?
No, sir. Not.
If no, I hand over the mic to host for
Yes.
vote of thanks.
Okay, sir. It was a wonderful workshop, sir. And we are very grateful to all the faculty members for taking their time out from their busy schedules and being with us today. I would like to thank Dr. Divya Goyal ma'am and Dr. Bhushan Joshi sir for presenting those interesting cases. And also thank you, Dr. Asokan sir, Dr. Jayanta Roy sir, and Dr. Mukherjee sir for your expert comments and great practical insights, sir. And we would really like to work under your guidance for many such future programs. So with this note, we will close this session, and thank you everyone again. Bye. Good night. Have a happy weekend, everyone.
Yeah, good night. Bye-bye, all of you.
Thank you. Good night.
Bye.
Bye.